If you want more than that, I'm very suspicious of you. The dosing of medication-assisted treatment needs to be personalized. Hey guys, welcome back. This is Dr. B. Look, there are three things that I think are quite important in considering when treating substance abuse in the era of fentanyl, if we can say that, meaning the prevalence of fentanyl in the opiate supply, drug supply, and increasing overdose deaths. Number one, 16 milligrams of buprenorphine or Suboxone. This is on the package insert labels. This is guidelines by Substance Abuse Mental Health, I believe, and other organizations. And we need to get over that. 16 milligrams is a guideline, which means the practitioner has to use their professional judgment for increasing the dose if necessary or decreasing it. It is not a categorical number that people are to be on 16 milligrams. And I'm shocked that we're still in that state, because if you go back long enough, the way you dose buprenorphine within that range of 0 to 32 milligrams is you titrate to the patient's cravings and withdrawal symptoms. And if you're really good, you can titrate to deal with a lot of anxiety, sleep, depression, and so on. But at the very least, it needs to be titrated to withdrawals and cravings in a 24-hour period, constantly, around the clock, day in, day out, week in, week out, period. It is not 16 milligrams as a target dose. In addition, a lot is made about the fact, well, this is since fentanyl. This is what it's always been, whether it's morphine, heroin, oxys. It is titrated to the dose, and people can end anywhere 16, 18, 24, 28 maybe to start off with and eventually go back, and some need less. Number one, that's our number one thing that we need to really consider so we can keep people on medication-assisted treatment so we decrease the incidence of relapses and overdoses. Number two, we have to start in a very progressive way understanding that substance abuse, opiate abuse, long time ago, it has changed. It's polysubstance abuse now. And so these patients are coming to you with very complicated presentations, and initiating medication-assisted treatment itself has different nuances that you have to consider, even beyond the issue of how long does it take before you induce, given the patient is on fentanyl, whatever that means. But they have polysubstance issues that lends itself to difficulty in initiating buprenorphine medication-assisted treatment in the induction stage, and you might lose a patient, and immediately following afterwards. Three, all of these things include systemic barriers, which tells me we've gotten not very far with reducing the stigma. This is a very complex, marginalized population where the disease process comes with extensive stigma that seeps into the systemic and systematic, creates barriers of care. Whether it's the doctor saying, hey, you got to get in here right now and give me that urine, or you're not getting your refill, or whether it's the pharmacy blocking you giving doses higher than 16 milligrams, whether it's the insurance companies blocking a higher dose or requiring prior authorizations. And this complexity and these issues really promote the stigma of the type of clients that you are dealing with, whether you're in a mental health facility or the patients you're dealing with, creating this identity of mistrusting them and not valuing what they say. They may say, hey, you know what? I need more. In the evenings I can't sleep, and they have all kinds of issues. It's a polysubstance presentation that is quite complex that also comes with mental health comorbidities, which a lot of these patients have. And the way the system is set up right now, and some of these issues that I have raised all feed into each other, creating barriers of care in operational procedures, whether it's the physician giving the medication or it's the facility dealing with these patients, how they get paid and how long they will hold them. Let me give you some of these examples. The idea that somebody is abusing opiates, methamphetamines, and benzos, plus has maybe underlying legitimate anxiety, depression, insomnia, mental health issues, which would have to be teased out in the long run if it's something beyond the substance abuse. These things create barriers. You can't expect someone to go into a detox facility or a treatment facility and demand that you strip them off all of these drugs within 10, 5, 15, 20, 25 days. In fact, it's dangerous. And also say, you know what, the target dose is 16 milligrams. If you want more than that, I'm very suspicious of you. The pharmacy not filling scripts more than that. The insurance company's not paying more for that. And the physician expecting a patient to come off of all of those things in that short period of time in a safe way, and for the patient to even be successful. We need to change our approach. We need to understand the complexity of this process that this population of patients go through. We need to understand the nuances of how to algorithmically approach the care of these complex patients and have a plan with a lot of room for changes as the presentation of the patient changes and you start to understand them more. So from top to bottom, and I raise this as an issue given the prevalence of fentanyl in the drug supply, increasing overdose deaths. And I pointed out these three things that are not just interrelated to each other, but seep out throughout the whole system of care that we are delivering and how society approaches these patients. One, the dosing of medication-assisted treatment needs to be personalized for each patient, given their cravings, withdrawals, 24-hour-a-day coverage, and it needs to be kept at that without any barriers or any stigma directed towards the patient and their complaints. Look, if you are an experienced clinician, you're an idiot if patient tells you they need 50 milligrams of Suboxone a day, or they continuously lie about something and you don't pick it up. That's on you to pick it up. Two, I brought out the complexity because it's no longer someone is a meth addict or someone is an opiate addict or has a substance abuse problem with benzodiazepines. Almost everybody's coming in with multiple drugs on board and expecting them to get off of all of those in the way the treatments are set up right now, given the insurance payments and so forth, is insane and inhumane. The doctors or clinicians need to really understand that patient and how to approach optimizing risk benefit to get them off as many things as they can and however long it takes. And three, this really speaks to these issues bring out the continued stigma of substance abuse, especially when you're demanding that a patient approaches things in a very specific sort of quantified way, like asking them to stay on Suboxone, 16 milligrams. That's a guideline, And all guidelines since the beginning of clinical time are supposed to be taken by the clinician with a grain of salt, staying within a certain boundary of care and providing care that works for that patient. Thank you very much. This was Dr. B, and please like and subscribe if you enjoyed what I had to say.